Follow-up MRIs can be valuable in two cases. One, if you have found nothing abnormal on imaging structurally, right? Yet the patient is so abnormal. The family doesn't recognize them anymore. They can't, work is not going well. Tasks they used to do, they can't do them anymore. Well, something's wrong.
TBI cases can feel like navigating uncharted territory. Your client's injury is real, but proving it, that's where the real challenge begins. If you've ever felt like you're missing crucial pieces of the puzzle, you're in the right place. Welcome to Winning the TBI Case, where Tom Crosley shares the insights he's gained from over 60 injury trials. Not just the victories, but the lessons learned along the way that make all the difference. Winning the TBI Case. Strategy, science, and storytelling.
Welcome back to Winning the TBI Case. I'm Tom Crosley, and today we're going to have an exciting episode. We're going to be talking about one of the most misunderstood areas in traumatic brain injury litigation, and that is brain imaging. Our guest today is Dr. David Levey, a diagnostic radiologist with a clinical practice, reading brains, spine, and he also happens to serve as an expert witness from time to time in legal cases. About half of his work is on the defense side. About half is on the plaintiff side. So he's one of those expert witnesses who is exactly what we want. Science first, advocacy second. Somebody who does both sides and calls the balls and strikes like he sees them. So I wanted to start with a little bit about you and your background. What led you to go to medical school? How did you pick radiology as your specialty? Kind of bring us current to the modern times.
Well, when I was 11, I read a book called The Defense Never Rests, and that was it. I was going to be a lawyer. And the next few years, that evolved, went to college, got 2 different bachelor's degrees, really heading towards the neurosciences, a master's degree at UCLA before medical school. So after medical school, a trauma internship, 4 years of radiology at USC, and a fellowship. In my 17th year, after 17 years coming out of the machine, I finally got my first job doing just that. Neuroradiology, musculoskeletal imaging here in Texas was the first job, and here I am.
Tell us about how forensic neuroradiology, for example, in a brain injury case, differs from day-to-day clinical neuroradiology.
It's extraordinary, the difference. And I didn't know about it until I started this 15 years ago. If you're reading a brain, you're reading an MRI of the brain as a radiologist, and you get the case comes up, you get some clinical data, you may get some clinical information faxed to you. Some of it's sketchy, some of it's from the patient. You may get some nursing notes, PA or the doctor, but it's variable. If you get 10 pages of notes, you're really doing great. If you get a page or 2, that's acceptable too. Many of the diagnoses are fairly complete, and others just may have headache or head pain or trauma. No date, no description, no time. You don't have any idea. So you are absolutely starting from the beginning and working your way through a brain MRI and trying to get that diagnosis. So you're looking for everything under the sun. You can't focus on a trauma or anything else. And that takes you X amount of time. A brain MRI may take 2 minutes, 2 hours. I've had one take 2 days, spent 2 days on it, getting through it. It was so complicated, but it's a finite experience. But forensic radiology, you get reams of medical records and a number of opinions from everywhere. From the police report at the scene where the accident is, all the way through the ER and the ICU and the consultants and surgery or not. Then the patient finally is released from the hospital and has all these follow-up appointments from many other experienced, seasoned experts, pain people, clinical psychology people, PM&R, et cetera. And the vast amount of information I can use to put a story together is what I think has attracted me at first to this field. And so all the imaging available, plus all the medical records together, allows me to tell a story, not only just with the radiology and the imaging, but the medical process and the path the patient took as well.
So some radiologists that serve as expert witnesses don't like to look at medical records. They just want to look at the imaging and dictate a report based on what they see. But it sounds like you like to look at the whole picture, including medical records. Why is that?
I think it's important. I do like it. You're right. But I also think it's important. I think you're missing something if you're not doing that, because first of all, from the correct diagnosis flows the correct treatment. When I get involved with any patient, it doesn't matter, defense, plaintiff, or what the situation is, what I'm looking for is, what is the correct diagnosis? What happened to this patient? And is he or she being treated correctly or properly? And that's a concern of mine, because I see if the radiologist, for instance, that read the primary studies got it wrong, then the whole crowd, medical, surgical, everybody, they're following down the wrong pathway. And that's the classic GIGO I see all the time: garbage in, garbage out. You get the wrong diagnosis and everybody's, there's surgery on the wrong place, or not surgery where he needs it. There's treatment that is inappropriate because the diagnosis was not made correctly in the beginning. So the medical records really help with that. Hardly ever get that when you just get a case, read it, like in a radiology practice.
It sounded like your explanation of the difference between clinical radiology and forensic radiology was sometimes clinically you might only spend a few minutes reading a brain scan. But if it's forensic, meaning it's going to be used in a court case, then you're going to spend probably a lot more time. Is that what I'm hearing?
I do. And I see them over and over again, because it may take weeks to get the consultative report out. But then if you have a deposition or are called upon on this case for any other reasons, it takes weeks, maybe months, that you're going over and over these things. I currently have a case that's on its 6th year.
Let's take a step back, Dr. Levey, and have you tell us what radiologists typically do in evaluating brain injury. And I'm not talking about experts. I'm talking about clinical radiologists. What's their role?
You get the scan, you pull it up on your reading station, and you have a dictaphone, one you might use, such as this one. If you're on YouTube, you can see my dictaphone. We live and die by it. And you evaluate the case as you go through hundreds of images. Now, they are set up in a reading situation where they're called sequences, and you'll do different sequences that weight the brain tissue different ways. And so you can look at them from different angles. If you're doing a CT scan, it's very simple. Usually it's axial images, it's an X-ray study, and it's black and white. You kind of zip right through the head, right through the head, axially. But now we can reconstruct these in other planes and see a lot more than we used to. So CT is valuable in the acute setting, especially. But then MRI it can have hundreds, and in some cases thousands of images. And we're no longer looking at pixels. This is one big thing that has changed. It was pixel imaging for decades in radiology, like X and Y, a box. And these boxes had images, and these images allowed you to look at the brain. But today we're looking at voxels, a volume pixel. So you have an X, a Y, and a Z. So there's a width, a height, and a depth in these studies. So now we have contiguous imaging, and we don't miss a thing. We're right on top and overlapping as you come through the brain parenchyma itself. And in doing so, you get the base of the brain. You get the orbits. You get the sinuses, the inner ear, the cerebellum, the supratentorial compartment. It's a fallacy that you're just looking at brain only. You look at everything that's in the field of view. You're responsible for that. And as a diagnostic radiologist, to answer your question, you get that study, you bang through those images, you make your report, you make sure you don't miss anything, and you're on to the next one.
In a clinical setting, what is the typical amount of time that a radiologist will look at a brain scan?
It's minutes. It's not hours, that's for sure.
And if it's minutes in a clinical setting, because of the volume of the practice of the doctor and the fact that they've got to read 50 or 60 or more scans a day,
that's right.
What is the amount of time that you typically spend reading that same MRI scan if it's a litigation case and you've been retained as an expert for the defense or the plaintiff?
First off, it has to be a little longer because I have someone else's report and I have the images. Okay. So I'm going to go through the images and I'm going to be looking to see what I call them the primary radiologist. You can call it the treating radiologist, what they said about the study and what they didn't. Whatever's on the image, you must report. We are not of a standing where we can pick and choose. If it's an abnormality you're finding and it's on a scan, you need to report it. And I see a lot of things being left out or misinterpreted. So that my first wave through is to see what the radiologist said. The next one is to compare it to any of the other prior examinations. And very special in my practice, I have a bird's eye view into all the other prior scans that many times the radiologists do not. I amass them, right? We download them, we get everything ready, whereas that radiologist may have one study, read that study, and he's on to the next one. It doesn't have the advantage of having prior studies. And it is so nice. So I have a unfair disadvantage in that I can see multiple years sometimes of brain scans and then see the current one. That's important. So yes, it takes longer because there's more material there, and I'm kind of doing my due diligence and a little bit of detective work as well to make sure that all the details have been seen.
Dr. Levey, in my litigation practice over the last few decades, I've had cases, certainly very commonly, there's a CT scan done in the ER. Very commonly, it's read as normal unless there was a fracture or bleeding. Does a normal CT scan rule out a brain injury?
It does not.
And is that something that every radiologist in the country should agree upon, or is that up for debate?
I think it's really not up for debate. And it doesn't matter what side you're on or even what specialty you are. I mean, if you look at a brain CT, and you don't see an abnormality, you know that there can be something there. And so many of the ones that I read is, no acute process. And you see these, no specific abnormality. Those are all true statements, but that doesn't mean there isn't something that is present that's not available to be visualized on the CT scan.
When a patient comes in with a suspected head injury and a CT is run on them in the ER, is the main thing they're looking for fracture or bleeding?
Those are two main things they're looking for as well. You can have post-traumatic stroke. You can have edema in the brain, so no blood at all, but a real good contusion can give you edema, and that edema should show up quite rapidly and be seen on a CT. But you're right. Fractures and blood are the number one and number two thing because they're seen so well. They're radiodense, and they're going to be seen as white, right? Or the absence of white on your image.
What I typically see with MRIs is if a patient is still symptomatic and weeks have passed by, then an MRI scan is ordered. And often in our mild cases, that one will come back as normal. But is that also just a structural test? It's looking at the structure of the brain and not the function of the brain?
It certainly does look at the structure, but the one thing that it has over CT or many of the other neuro testing you can do, is that it has, we have structural resolution and contrast resolution. Those are the two big things. And the MRI can look at the contrast between bone and fluid and fat, cortex and white matter and ventricles, all the different things, vessels, flow and no flow. So it's structural for sure, but it isn't as good as CT. It will never be as clear as a CT in terms of anatomical, but it's okay because it has gotten so good now. But it also has contrast resolution, which that is the most valuable thing that an MRI can provide. And because that relates to blood flow as well, the absence, tissue viability or the absence of tissue viability, and tissues can be injured. Blood that's old, subacute, or acute. All those things can be seen on MRI. So it's just a more versatile test than the CT scan.
In a plaintiff case, if you are retained early enough to where you can make suggestions about what type of imaging the plaintiff should receive, what suggestions do you typically make?
If it's a trauma case, I typically do not need contrast, and there's IV contrast material injected at the time of the examination. So a non-contrast, 3T, MRI of the brain. And I have a specific protocol that covers all kinds of disease processes, both the ones we're looking for, trauma related, and totally non-trauma related, because you have to examine the patient's brain in totality, because you get surprised sometimes what may pop up. Would I add a DTI to that? Well, you can't lose in doing that. And what I mean by that is the patient's in the magnet, they're on the scanner, the tech is doing the study, they're almost done. All they have to add is three or four more sequences. So if the patient can lie still for another 10 to 20 minutes, depending, and you can acquire this data, then I would say do that as well. And I would say to do that because I never stop. Thus far in my practice, I never stop with the DTI, get that study, look at it, report it out, and go. I always take the raw images and send them off to be evaluated for quantitative evaluation. So you can get this 1-2 punch. And now you have a ton of data on one brain, on one person, and you may or may not need it, but you certainly have it at your disposal to evaluate.
And is there a separate sequence that's run for susceptibility weighted imaging or SWI?
If we're saying we're going to do a DTI, then I'd need to be more specific. I'd package it like this. I want a 3T MRI of the brain, non-contrast, with all the typical protocols utilized, and also those that you look for trauma-related things, like an SWI or a GRE. I want the planes that I need, and I also add a number of sequences on the back end for DTI. That in and of itself would be one study that could be very useful because you could then ship the DTI and brain examination off for quantitative study. So what I like to say is what we've done here. We've done a 3T brain, non-contrast brain, and we've done qualitative evaluation of the brain, the imaging, and quantitative.
Is it difficult to get patients access to 3T scanners for brain scans?
Really, in North America, not really. In a normal setting, if a physician is sending a patient for a study and he wants the very best type of MRI, he should be sending it to an MRI center where he's already called them and said, hey, you guys have a 3T scanner? Will you always have that available? Oh, you haven't gotten it yet. I see, you're planning. Thank you, click. Go to the next guy.
So I've heard of a 7T scanner as well. When is it appropriate to insist upon a 7T machine?
Never, unless you're doing research on animals. Yet, we do not know that there is a clinically significant difference in image quality or the acquisition on a 3T versus a 7T.
So if it were your family member who had suffered head trauma and needed an MRI, you'd be recommending a 3T machine for the brain MRI?
Yes, but I know that I would, if I knew the 1.5 Tesla and I knew the tech was good and it was well kept in a good magnet, it would be just as well to get a 1.5.
So doctor, I had a question about when is the best time to get an MRI, and over the life of a case, which can sometimes go 2 to 3 years or even longer, how frequently should the plaintiff be imaged to look for changes over time?
If the patient in question had a trauma and they gone to the ER and got their head CT, if they're stable, there is nothing holding one back in the first week for someone to get an MRI. Because if the head CT is read as normal, the MRI could still be flagrantly abnormal. And you'd want to know that, because then you could track it over time as you re-examine them over the months or years. If the head CT is read as abnormal, you could further characterize those abnormalities in MRI, and so much better than a CT scan. And getting that detail also allows you to not only tell what's wrong with the patient now, but importantly, to prognosticate what may be expected in the future to happen to that brain, and therefore to happen to that person and their ability to think, their executive functions, and the like, memory, emotions, etc. So getting an MRI soon or early in the case is sometimes, I think a lot of lawyers wring their hands over that. I wouldn't. I would just go ahead and get it if it's possible.
And is it appropriate to order a repeat scan at some point?
At some point, I think so. Follow-up MRIs can be valuable in 2 cases. One, if you have found nothing abnormal on imaging structurally, right? Yet the patient is so abnormal. The family doesn't recognize them anymore. They can't, work is not going well. Tasks they used to do, they can't do them anymore. Well, something's wrong. You've had normal brain scans. You definitely want to follow up MRI and a high field strength at that. But if you had a prior scan and it's abnormal, same thing. You want to track that abnormality because, and this is the most valuable part, is that once you have established that the brain has been injured, and so many different injuries can occur, but then you want to know what the secondary and tertiary effects on the brain is. And those things, after the brain bleeds or has been injured or has had edema or infarct, it usually walks through a progression, not linear, a nonlinear progression of either encephalomalacia or gliosis or brain atrophy and any apoptosis of the actual neurons themselves, giving you groups of dead neuronal tissue that will never come back, is all part of the process of figuring out how will this patient do in the future.
I tried a case last year in another state, and the client was still symptomatic. In fact, her symptoms never went away, and it was classic post-concussion syndrome. And one of the important things to the jury in the case was that we had a volumetric study done early, and then about 8 or 9 months later, another volumetric study, and it showed a loss of brain volume in the interim. And that seemed important, certainly to the doctors in the case, and important in my proof of the case. So my question is there an optimal time to do repeat volume studies to look for that type of thing?
The literature is all over the place, and there is not an optimal time, but what you're describing is essential to these cases. I would think if you have T equals 0 injury in a scan, I think you need to wait at least 6 months to get another examination. But certainly it's going to be more valuable the longer you wait, as a general rule. That's not a hard rule at all, nothing hard and fast. But if it's at 9 months or a year and a half, you'll really see the effects of atrophy if you have it.
Can you teach us a bit about what is a volumetric study of the brain and how is that important in litigating a TBI case?
An MRI is performed. A neurophysiology lab typically will be able to take those images and feed them into a computer who looks at and measures volumes. And they measure volumes of lobes and of sublobe regions. And they subsegment each lobes. They may even take a cerebellum. In my volumetric studies, there's the lower brain, the cerebellum, and the upper brain, the cerebrum, right? And my cerebellar subsegmentation is there's 12 different areas of the cerebellum. Each are looked at what volume they are and what the normal population volume should be. You also look at what volume segment 7 is on the right compared to segment 7 on the left and compare them side to side. So you have an internal standard, and then also you have data, pooled data from what normal should be expected to be. And so it's calculative, informational data that's extracted from raw MRI images through computer programs that allow you to calculate those volumes in various areas of the brain.
Doctor, when you're examining DTI, what is most persuasive for showing traumatic changes to the brain?
Certainly, you must take the whole picture into account, but it is valuable to see if you can identify what should be a normal fiber tract appearance, if there are less of them, if they're thinned or attenuated, if they're blunted or thickened, if they're shortened, or just simply transected. They should be continuous, but they're transected. Now they're in 2 pieces or multiple pieces.
Doctor, on the screen now, you are showing a tractography of a human brain. And what is significant about tractography in traumatic brain injury cases? What are you looking for?
Well, to put it in a layman's way of describing it, every time you look at an MRI and you look at the images, they're slices or they're an image. They're a part of the brain. And that's a 2D representation of a 3-dimensional thing. Like your head is 3-dimensional. So is your brain. But tractography at least attempts to get a 3D image of the brain. And you're able to roll and spin these images so that you can take a look at both sides, one side or the other side, and do your comparison. So I will turn this one on. And if you see it rotating here, for those that cannot see it, basically you have from front to back, again, color-coded red, green, and blue, these different directional evaluations of the tracts that are there and the tracts that are missing. And if there's injury or absence, injury to the brain, you put it together, of course, with your standard MRI, your DTI, your quantitative studies, and then something like this, tractography, is yet another way of looking at the brain and evaluating for presence of disease.
So you're looking for missing bundles of fiber tracts from which you can conclude that there's damage to that area.
Yes. If the fiber tracts are shortened or thickened or attenuated, if they're splayed or absent, anything that takes away from the typical configuration of the brain and the fiber tracts therein and the actual neuron fibers themselves, that's a great way to identify whether a brain has been injured or not.
Sometimes in my cases, there will be a defense retained radiologist who says that whatever is visible on the imaging isn't related to traumatic brain injury. Sometimes they'll call it pre-existing white matter disease or small vessel ischemic changes or, age-related findings instead of trauma-related findings. So can you teach us a little bit about how radiologists figure out whether it's trauma or something else?
That's pattern recognition, and those that are trained and pay attention and spend their lives doing this should know when you have chronic white matter ischemic changes, and only that alone, and you have a patient in their 50s, 60s, 60s, 70s, 80s, and perhaps they're a smoker or have had chronic migraines for 50 years or have some other diabetes, some other intercurrent disease, that pattern should be microvascular disease, and it's okay. It's okay to call it that, and they could have had the worst trauma and all the stories and hospitalizations and good stuff. If you don't see trauma or evidence therein, you can't call it. And so if a defense guy gets a set of brain MRIs or CT scans, they know that the patient's had trauma and they're evaluating it, and they only see microvascular disease. It's incumbent upon them to just call it that and stop.
How do you approach causation analysis as a radiologist to help us identify whether something was or was not caused by trauma to the brain?
I'm certainly not shy, and I'm happy to do it when it's there. When the elements of being able to connect the dots for causation is there, I'm very upfront with that analysis. But it's infinitely easier on a defense case than it is on a plaintiff case. Okay, because when something's not there, that's the easy part. You can talk about patient had trauma, had this, had that, and I'm looking at multiple studies. I'm looking at 2 or 3 CTs, multiple MRI examinations, maybe a DTI exam, etc. And if the data points to the fact that there is nothing there that is trauma related, I can say the patient may have had a terrible trauma, and there may be pain, disability, connective tissue, even long-term effects. But if there is no fracture, then that bone's intact. If there is no blood, if there's no brain abnormality, it's a frankly normal study, then there's nothing to correlate, and so there's no causation.
So what are the types of things that you're most often called upon, say, in a trial to testify to on behalf of the defense?
In a nutshell, it's the absence of disease. It's that the claims are one thing that the radiologist said on whatever study that this is present. The surgeon or other doctors may be quoting the radiologist and carrying that patient for months and even treating them in such ways, even with surgery. But if the images show the absence of disease, it's the thing I can state. It's the thing I can lay out there for all to see, judge, jury, it doesn't matter. And then if I need demonstrators, let's see that scan. Well, I can show that scan, show the absence of disease. It really is quite simple.
So, doctor, I find it difficult to cross-examine a radiologist because I can't really tell them that the pictures don't show what they say they show. I can't get in that debate with them. I'm not really qualified to do that. And so what have you seen be effective in cross-examining a radiologist? I mean, clearly we can talk about how much money they've been paid or whether they're biased or whether they only report for the plaintiff or only report for the defense. Those things clearly work. But if we get into the merits of the radiology, what else can we lawyers be doing?
This is what I don't see. I think this would be really helpful for an attorney, would be to consult your favorite radiologist first before you get up there. You can really, I do believe, and you can tell me if it's true, that plaintiff or defense, you guys practice, you guys get ready, you get ready for trial. And there's a lot of preparation. And in preparation, if I was an attorney and didn't know radiology, I would have a radiologist in my ear. I'd be pointing out stuff, and at least I'd be able to conversant, and I know which questions to ask. And I know that I couldn't compete with him like in the weeds on fine, but I would know already that if he's going to point to this area, or he's already said it's just chronic microvascular disease, then I would have an area, if the radiologist thought there was an area that was different or didn't exactly look like microvascular disease. I would have that up. I had it circled. Well, how about that, doctor? That doesn't look like microvascular. Do you think that looks like microvascular disease? How about this one? And I personally don't know if you can quote radiologists or have them come on. If you can bring your own radiologist on, right, and cross-examine him for what the other person had said, that would be valuable.
Sometimes they like to say, "Oh, I didn't consider the DTI because that's not validated in a single person study. It's more for research or whatever, so I didn't look at it. So I'll cross-examine them on the, FDA approvals and the other uses, et cetera." But it's very difficult to tell them that you see something different on a scan than what they see, because I can't credibly argue on that level.
The 12 Dauber challenges I've had with DTI, they're 0 for 12. I would say that over 90% of the ones that even be taken to task and they try to limit you and all, they really are not, they haven't been very successful in doing that. And that's because there's too much data showing that the last 30 years, this has been used on patients. And, the truth is it was used on patients early for stroke and tumor and a lot of, seizure, a lot of other disease processes. But we do advance on. We do look at things, and there's a massive amount of information now to use this for trauma. And I've done it long enough to see and spend enough time digging through the literature to see that it's valid and you can show it. It would be tough for a jury to sit through, going through research paper after research paper to show that. But again, if you're prepared, you can do the short version, hopefully.
Doctor, where do you think the science of radiology is headed, specifically in brain radiology?
So everyone likes to talk about AI, and AI is actually great for hospital radiology, where you're plowing through tons of studies. Some of the best uses of AI currently right now are in cardiovascular radiology. And without going into too much detail, looking at the coronary arteries in a way that they've never been looked at before. And it turns out all of those vessels that are in the heart are in the brain as well. So the vascular function, or the lack thereof, in the brain can now, and is starting to be looked at. So I think AI of the vascular system may be the first newest technique for the brain. And past that, I think there are going to be perfusion elements. We use gadolinium as our enhancement now. And I think there are other perfusion elements that are going to allow for looking at different subsegmental areas of the brain and looking for a lesser or greater function. Wouldn't it be valuable? Wouldn't it be something if you could give an injection to a patient and do a brain MRI and see what areas are functioning to a lesser or greater extent, or which are dysfunctioning or abnormal firing of neurons, et cetera, without having to get a PET scan? Because the PET scan, you get the radiation, and the spatial, how clearly you see the structures, will never be as good as MRI. So I'm thinking injectables and AI using for the vascular technique to look at vascular brain anatomy might be some of the inroads coming up.
Now, we've talked a lot lately at conferences about blood biomarkers. Is there any intersection between blood biomarkers and radiology and brain imaging?
I think like any other blood test or any other test that can dovetail with radiology, it can certainly be valuable. I know that I'm looking into them now, those biomarkers, because of their possible value in trauma, in acute trauma, and the effects of chronic trauma. So, but I don't think they'll help the radiology per se. We'll still be doing the job that we do every day. But if we know we have a confirmatory test, that's always valuable.
What is one piece of advice you would give to plaintiff lawyers, or that you wish that they understood about radiologists in brain injury cases?
I think that plaintiff lawyers are subject, and should not surprise anyone, to bias. And I think it's their own personal bias, because they want this case to go well, and they want things to go well for their patient, for their client. I mean, you are working for your clients and their families and for their legacy. I get that. The one advice is, if you can get someone who likes to work with you, do that. The more interaction you have with your experts, sitting down, converse with them, probably the better, because you can get creative sometimes in a positive way and in an honest way. And it makes the case better and more robust.
When you're hired by the defense, what is the one thing you wish defense lawyers understood better about radiology?
If the case is positive, as badly as you want this to be not an injury, not a brain injury or a body injury. If I'm seeing evidence of injury and it looks acute, you're done. And so really I help my defense guys two ways. One is by doing their case when they're right. And the other is telling them early, hey, get out, settle this because you're wrong. And there's no, you could find some other person to say another thing. That would be a bad thing to do. This patient's been injured. How you're going to go about settling it, that's up to you. But I will point everything out to them. I won't just say, hey, you got a bad case. I'll take them through everything, fractures, cord injuries, brain injuries, whatever it is. So let them know the extent of what's going on. But I think it's incumbent upon me to get in early and let them know early to get out. That this case is not valuable. And it's really the insurance company's duty to settle and take care of the patient that's been injured. So we're doing the right thing.
Well, Dr. Levey, thank you for your time today. I've really enjoyed our interview, and I feel like I've learned a lot from this. If any of our listeners wanted to get in touch with you, what is the best way to do that?
Well, they can always email me. That's always a very easy way to do it. So dlmdpa@expert-rad.com. In addition, I do have a website, www.expertradiologist.org. There's a lot of information there as well. And there's a page on DTI.
Thank you, Dr. Levey, for sharing your expertise on radiology with us. It's fascinating to me in a brain injury case, all the various modalities that are available to scan the brain, to look at the brain, to look at function, to look at structure. And the science has just changed so much over the 20 years that I've been doing these kind of cases. And I'm excited always to learn from you on this fascinating subject. So thank you for joining Winning the TBI Case. I'm your host, Tom Crosley.
If today's episode helped you see your current case in a new light, share it with a colleague who's facing the same challenges in a case. Subscribe wherever you get your podcasts and join our community of trial lawyers who refuse to settle for average results. This has been Winning the TBI Case. Strategy, science, and storytelling with Tom Crosley.